The presentation is in English, pero es que yo quería darles la bienvenida antes de empezar para que ustedes sepan cómo es ir a una agencia, a una organización sin poder entender lo que está pasando. Vi que algunos de ustedes tienen nombres que indican que es posible que hablen español, pero and as I said, this presentation is in English. I just wanted to say a few words of welcome to you in Spanish so that you have that little tiny bit of sensation of what it's like to go to an agency where you're needing to get information, you're needing to get services, and you are not able to communicate in the same language as the people that you may find in that agency. So having said that, thank you so much for taking an hour out of your busy, busy time and for attending the seminar, the webinar. Also, thank you for having an interest in serving the Spanish-speaking population here in the Commonwealth. It means a lot to all of us. So if you notice, I called this Spanish Speakers Speak Out About Mental Health. And the reason I did, we'll talk about in just a minute, but this was on the flyer that we're going to talk about the diversity of beliefs and experiences with mental health and developmental services across the Commonwealth. We'll talk about the barriers that prevent people from seeking mental health services and all the suggestions, which is the bulk of the presentation, the suggestions that people made for making healthcare, mental health care services more inviting and accessible. So I have all the names, or not all, but many of the names by which we refer to people. And this is a pretty important piece of the presentation because in any organization, any agency, if people are filling out information, there's a good chance that they will be asked to identify either race or ethnicity. And just to give you a very brief background, Hispanic is a term that was conceived of by the folks that do census here in the US, and referring to anybody who speaks Spanish as Hispanic is akin to our being in a country other than an English-speaking country, and we have to fill out a form, and the only option is to say we're English, and we're, you know, we do not tend to identify ourselves that way. Some people do identify as Hispanic, but it's a very loaded kind of term. The terms Latino, Latina, and so on, those came from the Southwest, and they were political statements. They refer to the fact that people are or have heritage from south of our border, from Latin America, which includes Mexico and South. And it also includes people who speak Portuguese. This, if you look at Latinas with the, not, how do we say in English, arroba, what you use with email, that is to make it the A and the O, and that was a term that was used in written material for a while. The current one is Latinx, which includes all people regardless of gender identity and so on. The thing that I have found out with this term is that with many of the people in the community, when they see the term, they'll say Latinx, what is that? I'm Mexican, or I'm Honduran, or whatever. Nationality is how I have found that most people tend to identify themselves. And my way of kind of having one term to talk about people who speak Spanish or who are from a Spanish-speaking heritage is to call them Spanish speakers. So that's just a little bit of extra information. So we had focus groups. We did widespread recruitment by email and through notices on social media. We targeted just a second. We targeted people whom we knew. We targeted our networks and asked them to send this to everyone that they thought might be interested, and we asked for them to disseminate it widely. With all of that, we ended up with 5 focus groups, and those focus groups each ran from 1.5 to 2 hours. We had a total of 13 participants. It was all via Zoom. We had 18 people who signed up, but when they actually showed up, there were only 13. We offered the focus groups at different times during the day, keeping in mind that people who are working have different schedules. So some were scheduled in the morning, some afternoon, and some in the evening. The facilitator for the focus groups was my colleague, Tanya Torres, who has her licensura, which is the equivalent of a BS in psychology from the UNAM, which is the largest public university in Mexico. And I mentioned not only she was so much a part of the whole project, could not have taken place without her, but also if you want to do focus groups, I think it's crucial that a member of the community, the Spanish-speaking community, be the facilitator, because even those of us who are bilingual and are not part of the Spanish-speaking community by birth, by our very being, we are still outsiders. These focus groups ran from September until November of 2020. And we had a survey that was to collect demographic information in Spanish and in English. And that was how we determined that people were, in fact, eligible to participate in the focus groups. As I said, we offered various dates and times. There was the option of Spanish or English, and there was a $30 gift card as a reward for participating. And it was with the proviso that if it was necessary, we would be able to go back and do a qualitative interview with people. There were a very few people who said that their preferred language would be English. And because there were so few, we wrapped them together and all the focus groups were conducted in Spanish. This is the geographic reach of what we did. We had hoped to get all of the regions in the Commonwealth, but we ended up with these 5. And we had one woman who lives right on the border in West Virginia, but her services had all been through the Commonwealth. She had lived here for a while, she'd gone to school and so on. So we did include her data. And here is a little breakdown of who the participants were. And the gender identity, there were 12 females and 1 male. The race, they chose all 3. Only one person chose multiracial, and the others chose either Hispanic or Latino. And something I read recently about biracial and multiracial is that people who have parents who are from 2 different cultures tend to think of themselves as all Latino or all US, depending on the circumstances, but they don't tend to use the multiracial or the biracial. Just another bit of trivia for you. From the 13, there were only 5 countries represented: Colombia, El Salvador, Honduras, Mexico, and the United States. And we have, as you know, many people who are born to parents who are from Spanish-speaking countries, but they're born here in the US. Many of them speak English as a second language, and I'm sure you know that. The age range was from 18 to 54. The formal schooling was from grade 1 through having a graduate degree. And the income, there were 2 who had no response. Otherwise, the income range was 15,000 to 100,000 and up. The insurance was public, private, uninsured, and unknown. And Glencora shared the report for you. If you want to have all the specific numbers, they're in a chart in that report. But I think it is important to look at this demographic information, because I think it's fairly representative of what we see here in the Commonwealth. We talk about the diversity, and there are Spanish speakers who are highly educated. They have graduate degrees that include medical degrees, university PhD degrees. It's all over the map. The racial identification is not just one. The countries of origin, this is just a small sampling. We have so many ages and so on. So the point of this is that we can't say all people who come from Spanish-speaking backgrounds are. I don't know that there's anything that we could fill in a blank and use all are. The employment, this is the employment breakdown, and I'm not going to read it to you. I'll leave it and let you look at it. The diagnoses, some were clinical and some were self-diagnosis. If I did not put a number in parenthesis following the diagnosis, it means there was only one person. If there were more than one, I did put the number. And you can see that the primary diagnoses, or the ones that showed up the most often, were depression and anxiety. And you can take a look and realize which ones are clinical and which ones are probably self-diagnosis. And I saw, as you were signing in, that you come from a variety of backgrounds. And I forgot to introduce myself, but for 22 years, I was teaching Spanish and education at Virginia Tech. I taught teachers who were going to be teachers of ESL, Spanish, French, German, and Latin. And I taught a course on diversity, I think, for all the semesters I was there. And I still, when I saw ASD, I did not know what that was. You probably do, but I had to look it up. It's autism spectrum disorder. So I would assume that one might be a clinical diagnosis. I retired from Virginia Tech on June 30th. I'm now adjunct faculty at Roanoke College, again, teaching Spanish. And I am a professor of an institute in Chihuahua that I teach PhD courses on critical pedagogy. But I have been working in the Spanish-speaking community since 1970, when I was the first ESL teacher for the Illinois Migrant Council in Aurora, Illinois. So my roots in this community go very deep. And so a lot of this is based on years of experience, as well as on what people said, the actual data. So before we go on to the guiding questions, I thought you might like to hear from Tanya about what it was like doing the focus groups on Zoom. Here, I'll just move over and you can slide right in.
Hi, everyone. Well, I think that my most important comment is that the focus groups were, it was like talking to friends. They were very supportive to each other and even giving recommendations on what to do and sharing concerns. So it was more like a talk between friends. So it was really, really helpful for them to open and to share their own experiences. So it was also very uplifting for them, and also all the information that we got was great.
Thank you. And it was kind of interesting because when we first realized we would be doing this by Zoom, my immediate thought was, oh my goodness, will this work because of technology literacy and because of sharing and the personal aspect and seeing the person in the video right there in front of you. But I think it was actually an ideal way to go about doing this. And I have to say that Tanya, and this is important because this shows up over and over, but Tanya has an extremely warm and inviting persona. She is, I've watched her working with people here in the office, and she just causes people to want to open up and talk. And I think for that reason, the data that came out of these meetings tended to be authentic data. I don't think there was any of, I'll say what they want me to say, I'll say what they want to hear. And it was just, as Tanya said, it was a sharing among friends. So keep that in mind if you do focus groups and when you're providing services. Our guiding questions were, how do Hispanic Virginians across the Commonwealth articulate their understandings of behavioral health, mental health, and the services offered by DBHDS? What are concerns and barriers with receiving services? What are the similarities and differences among the 5 geographic locations? And how can their perceptions help to make behavioral mental health services more accessible and inviting? We did not have a large enough group to make any generalizations about similarities and differences among the 5 geographic locations. I have wondered if I could go back and analyze really seeking that information. I've also thought that another analysis would be to look at, to match up who said what and match that with education, with economic status, and so on. But as it is, this is a very just sticking with the data and analyzing what was said and going from there. So here are the interview questions, and I will again let you just take a chance to read those rather than hearing me read over and over. We had 10 questions, and they were all fairly open-ended, inviting, sharing, again, authentic sharing. That was not the kind of loaded question that's seeking a specific answer. And I think they did give very honest answers. We had themes and sub-themes that emerged from the data here with their understanding of mental health, the clinical understanding, and that was very tiny. I had expected there might be more, but there wasn't. There was a lot about behavioral manifestations And there was a lot about the hidden behaviors, about people being quiet and so on. I would seriously suggest that you go to the report and read the quotes that Tanya excerpted from the recordings of the sessions, because they're extremely telling. And I thought about including them, and I thought, oh, with an hour, we can't do that. But the quotes are very powerful. And another thing that I did want to mention, if you're considering doing this kind of research, I translate all the time, especially from Spanish to English. I can read it and it's done. But with these, I really had to think a lot about how I was translating, because the registers of language were varied. As you might expect, some of the people spoke with very educated Spanish. Others, it was colloquial. It was like my dad was a coal miner in West Virginia, and I grew up in that environment till I was 12. And reading them, I thought about my family and the way my family spoke in English, and it was that kind of Spanish. So in doing the translating, I worked very hard trying to be true to the register of language and the feel of the language. And I hope I was able to capture how people were really expressing themselves. But that's another thing that you want to keep in mind when you're providing services of any kind to people whose culture and language are not your own. Their impressions of DBHDS, that there was a lack of linguistic and culturally appropriate services. There were a number of quotes about how it's not just language, but it's understanding how people in a culture express themselves, how they talk about their concerns, and that there needs to be some kind of training to prepare people to recognize the linguistic and culturally appropriate ways of working with people. More about that in a minute. Also, that there was a lack of sufficient communication and concern. And some people mentioned that when they go into the place where they're receiving services, that they often feel ignored while the person who's there at the desk is taking care of other people, that kind of invisible feeling. They talked about the need for advocates and education, and we'll talk more about that, and the superiority of public rather than private services, which is very much that matches what my experience was. I was an interpreter at the health department for 4 or 5 years. And at the same time, my daughters were receiving services, prenatal, postnatal, family planning services at a private, a practice. And I always felt like the services that the women at the clinic received were superior to the services my daughters received in their private practice from their private practice physicians. So when I saw that, I thought, oh, I bet it's the same with DBHDS. The themes and sub-themes, barriers to access. Again, language and culture, it popped up everywhere. The language and culture piece, the lack of resources that people have, that they have limitations in terms of financial issues, time, because if you are working a wage job and you have to ask off time from work, many places, if you ask one time to go for a medical appointment, you might be excused. Second time, the eyebrows are raised. The third time, you might be given a warning, or worse. They talked about the lack of insurance, and they talked about fear having to do with their legal status. They talked about a lack of understanding among the community about what mental health is and what psychological services are. And this was all through the data as well. Also, a lack of knowledge about rights, that, for example, to receive state services, it is every person's right to have an interpreter who speaks the language of the person seeking rights. And people don't always know about that. They'll bring their kids to translate, to interpret. Interpret is oral language, translate is written, just another piece of trivia. But they'll bring someone that will serve as an interpreter, and it very well might be someone that they don't want that person knowing about their personal issues, so they won't give that kind of information, or they'd be embarrassed or whatever. So they need to be aware that they have the right to an interpreter. And then cultural beliefs, there we learned that there is a real stigma against receiving mental health services. And again, I thought about my family in West Virginia. If you have something going on with your mental health, there's a tendency to hide it in this culture as well, and to not want people to know that that's going on in your home. The themes and sub-themes again, the reason people do seek services, they desire services for a family member. And from the data, you can see that sometimes people will go beyond their own hesitation out of deep love and concern for a family member. They will also become extremely, I almost want to say militant in seeking services for a family member, because they know that family member is really in need of the services. And there is a need, they want to have a retraining of the family with problems. Usually when they talked about that, it had to do with addiction, but that the problem is not just an individual problem, it is a family unit problem, and that needs to be dealt with as well as on an individual basis. People also, someone talked about hope and a new dawn, a new opportunity for living a better life. And then I love this fourth one, a desire to have someone who worries about you. I thought that's very touching. And these last two are like a real call for reevaluating how we're dealing with people in any kind of services, in particular here with mental health services. How do you, as a provider, how do you give that message to people that you want to help them find a way to live a better life, and that you worry about them, that you care? So the suggestions, I think there are 3 slides here about suggestions, which is very wonderful, I think, because these are their voices. And I think because they were talking with Tanya, who is a member of the culture, she is not a mental health provider. So it was like not talking to the person that you're wanting to give suggestions to. It's that, I don't know if you're familiar with Appalachian signifying, that you don't come right out and say it, but rather you say, well, my friend thinks that, and then that's how you're communicating. But they think that there needs to be more specific information about agencies and the services that they offer in Spanish, and that Information needs to be concise and clear in Spanish in key places, including on the internet and through social media. They suggested having print material. They said everyone goes to the pediatricians, everyone who has kids goes to the pediatricians. So in your city, your town, what pediatricians see Spanish speaking families. So you put information available in Spanish at that physician's office. All the places, you know, they go to WIC, they go to the health department, all that we could name all the different places in town, even restaurants, the tiendas, the stores, everywhere that you know people go, have that information available. And don't put it just once on social media. If you have something going on, keep it rolling once a day, once a week, whatever. And provide information in a variety of ways, including video and print materials. Keep in mind what the grade levels were. And here at Casa Latina, we have learned that for a certain segment of the population, literacy is pretty low. We have a Plazas Comunitarias program going now where we're tied up with the Mexican consulate, and people can do literacy and then primary and secondary, which goes through 9th grade. And we have several people who are signed up to do literacy because one guy said, well, he can kind of write his name. And that was the extent of literacy. And we need to always keep that in mind, that you can't say, well, it's printed, therefore it's out there. Be sure if you're putting things on social media, that if it's not a video, have a lot of what do you say, visuals that would help to communicate what it is you're talking about. Check for clarity of information without technical and formal terms. Avoid jargon. And another thing that came up is that if you get a group of people together from a number of different countries, they'll say, well, in Puerto Rico, we don't say that. In Mexico, we say this, we don't say that. But keep in mind that there is a standard Spanish that everyone will understand. Keep it at a fairly low literacy rate, because you know everyone whose literacy is greater than that can understand, but always be seeking. There are a lot of folks here in Roanoke, at least, who had primary school, some through 2nd and 3rd grades, so they can read, but keep it on a very simple level. And there are people who could read if it were at a PhD level, but I'm just saying, if you want to be able to have everyone that you want to target, you want them all to be able to understand what you're trying to communicate. Keep that in mind. Another thing is to be straightforward and reassuring about confidentiality. This goes back to the stigma piece again, because if you are embarrassed or feeling like a real failure, or any of the other terms that we could use in seeking mental health services, you want to be sure that what you share with someone is going to be held in total confidence. So, you know, you can't just assume that people understand that. All this came up in the data. You cannot assume that people understand that if they make an appointment with you, it will be held in confidence. It needs to be stated right there. Everything that you share with me will be held in total confidence. have campaigns and community activities to disseminate information in Spanish and to generate confidence in the community. And I'm thinking again about Roanoke. We got a grant from Roanoke City to work with youth against gun violence. And so our campaigns have been just constant to get people interested in coming to learn about alternatives to gun violence, about all that gun violence can do. But it's this community and campaign that you focus, maybe you say this month we're going to focus on one thing, another month on another, and just get that information rolling constantly. And think about the community that, think about again, where people go. Churches are huge. And the churches, again, we have people who are Catholic, which is what those of us educated at a certain time in history would expect. But there are also people who are Pentecostal, Baptist, Mormon, Jehovah's Witness, Seventh-day Adventist, the independent churches. That's just to mention a few of the groups. And so if you have a way of getting your information to all those pastors and priests, I think you'll find that the information gets out there. They said that you should always have Spanish speakers available for reception and information as people enter. And this was one place that they said it didn't have to be a native speaker, but just someone who was able to communicate in Spanish. And even if your budget doesn't include that, what they did at the health department that I think might be a suggestion, I was called in for what they called the Latino clinic. And that clinic just meant that on Tuesday afternoon from 1 to 5, they scheduled as many of their Spanish speaking patients as possible. The same on Thursday. Just you choose a time slot and you call that your Spanish clinic or your Spanish, whatever it is that you're offering, and you schedule people to go in and you make sure that you have an interpreter at that particular time. Even if they come in at other times, if you could have just little tiny Spanish classes for people that are working in your agency, even if all they know how to say is hola, buenos dias, ¿cómo estás? And that creates that sense. Look below, it says create a sense of welcome, empathy, and concern rather than an exclusionary environment. But someone sitting at a desk looks up, has a smile in his or her eyes, and says those few words in Spanish. There's a sense of, I'm here for you, I care about you. To implement professional development sessions to educate providers about linguistic and cultural knowledge and appropriateness. And this is something that is so crucial. And it encompasses so many things. Each professional development would be geared toward the service that you provide. Because, for example, when I was doing the prenatal, postnatal interpreting at the health department, there were women who would come from extremely rural communities where they said they walked 4 hours to get to the doctor in the next nearest town. And they would talk about their body parts, and I would have no clue what on earth they were talking about. And I'd had a PhD level interpreter and translator course, and I still didn't recognize, and I learned how to find out, okay, so show me where that is, that it hurt, tell me what it feels like. And you can do the same thing with mental health services or developmental services. It's all about figuring out how to communicate with people and to get around any kind of linguistic barriers, linguistic and cultural barriers that might exist. And there were several who suggested that there needs to be a Spanish-speaking advocate who can clearly explain their rights. I would say their rights and the confidentiality factor, but someone who can say, you know, this is how it is. It doesn't matter if you have a legal presence in the US or you don't, that you are still eligible for all these services. No one will ever turn you in to ICE. This is all just between you and your service provider, all those kinds of things, a right to an interpreter, a right to having information explained in your own language. And another thing that came out of this is that people need clear information about sliding scale payments on all relevant information regarding services. And once you start doing this, and you might already do this, I know the health department was very good about it, but the word will spread. But that, you know, that all these things, if you came from a tiny village in Honduras and El Salvador, any of those, anywhere south of our border, and you've never been exposed to any of this, you need someone who can explain it in clear and plain language and say, look, this is what's there, and let me know if you have questions. And again, this popped up, but you need to prepare to treat the family, not just the patient. And it's, again, going back to our gun violence summer hangouts, we have a member in our committee who is not accustomed to the committee, and he thought we would just be seeing middle school through age 25, which is how I wrote the grant to get the money, but it's not, it's the whole family. You know, the youth are there, the middle schoolers are there, but it's the whole family. In the US, we tend to not operate as family units, but this is a culture that does. And so it, you know, figuring out not just one person, but the whole family. This is another one to increase parent and student awareness of mental health and substance abuse through interdisciplinary work and contact with schools. And the next one goes with it. Consider the schools as your partners. And someone talked about how the counselors need to be given professional development so that they understand how to work with their Spanish-speaking students and their families, and to help them to get the services that they may think they need, that the counselors think the kids or the parents need. And this was another one. This was another one I loved. And this is right from the quote, regard behavioral and mental health care as holistic, regarding the whole person and not just the issue that brought the client to the agency seeking care. And again, I would suspect this would be true of any services for any group, but especially in a culture where the family is a unit, and you know, there are all sorts of things going on. So overall, and these are my takeaways from all that I read, be sure to use only professionally trained interpreters. And professionally trained interpreters understand that they don't edit what anybody said. They don't make any changes. If you're really doing the kind of job interpreting that needs to be done, you even speak in first person. And that way, you know, when you're doing the Spanish and when you're doing the English, if it's in first person, just saying the words the person said, you'll find that each of them forget that there's an interpreter. It'll feel like they're, sorry, just a second. They'll feel like they're having a conversation just with each other. This is huge too. Remember that low literacy levels are unrelated to intelligence. Literacy levels often are the product of people's backgrounds, the inaccessibility of schooling. The same people who walk 4 hours to the doctor in town have to walk 4 hours to school. So they might be the smartest people in the whole world, but they don't have the literacy level. Also, I think that we can add technology literacy, because I think most people have a phone. Most people, or a lot of people, have a smartphone. They're able to navigate all over that phone, but that's still not like having computer technology literacy, that you can look things up on the internet. You can go to web pages. Maybe they can, likely they can, but that might not be part of what they do. This is, I'm sure you pick up that this is from me. Learn to listen and to hear with your eyes, ears, minds, and heart. When you're working with any group, and especially with this group, if you're attuned to tone of voice, to body language, and you might want to get that cultural competency so that you recognize that body language is different across cultures. I was interpreting in court, and the kid kept his head bowed when the judge was talking to him. And the judge said, "Son, look me in the eyes." And this was one time I stepped out of the interpreter's role and I said, "Judge Trumpeter, he is giving you his absolute respect by not looking you in the eye. That's a symbol of deep respect." And the judge said, "Oh, okay." And so he went on, and there was a whole change in the way he regarded him. But it's all of this that, and it's again part of that holistic treatment. And then again, you have figured out, this is me, regard all clients in a way you would like for your family to be treated in similar circumstances. So, time for questions.
Wonderful. Thank you so much, Chris, for sharing that and that great presentation. And just a reminder for everyone who would like to answer a question, there is a little Q&A tool generally it's at the bottom of your Zoom screen, and you can enter a question there. And if you would like to, you can answer it anonymously. And just before we kind of move into the next section here, I just want to make sure I just put into the chat and the FFHY as well, a link to the evaluation, a link for the request for a certificate, a way you can join my listserv so that you will be able to, or will be contacted for future presentations. And I also put a link where you can access the report. And if I'll also send a PDF version in the follow-up as well. All right, I'm going to move along here to the questions. The first one we have is, this person is asking, they work in early childhood mental health, and what are the recommendations for DBHDS or even a CSB to support awareness and resources for Spanish-speaking families who have concerns about their children's social, emotional well-being and mental health?
I guess I'm wondering how did they become aware that the child needed any kind of assistance? And again, it's bringing the whole family in, meet with the family, have that interpreter there, have the environment to be one that's welcoming. And remember that even if kids, a lot of times when kids are brought up in a Spanish speaking family, they won't know English until they go to school, and then they'll learn fairly quickly if they don't have developmental issues. But remember that visuals cross cultures. So as many visuals as you can use to work with those kids, and as much, make a total fool of yourself. Act things out, draw pictures yourself, communicate in every kind of way. I hope I answered.
Yeah, I think that's a great start as a way to begin, definitely using visuals and communicating with the whole family. I have one here. Somebody is asking for more specifics about the themes that came up dealing with culture. And if you could elaborate on it, especially with some of the participants from different countries, can you share an example?
One that I remember specifically is someone had a relative who needed services, and they felt like because of the person's culture, the person, I think it was a father, best I remember, who was released before he should have been released, and not understanding that in that culture there was nobody at home to take care of the relative. That this is a culture where everyone is out working, trying to keep food on the table, a roof over their heads. Again, the body language, the eyes, that would be one of the biggest examples that I could think of. Oh, another thing that I have run across over and over, when people are listening to you and they are respecting you because you are in a position of being a professional, that there is an automatic respect that comes with your position. And so there doesn't tend to always be that kind of pushback like we might have with people here. And there'll be a lot of head nodding. And in the US, when people are going, what do we think? We think, oh, they understood, or oh, they agree. Nope. It means quite often, it means I hear you talking. I see that you're explaining something to me. I hear those words falling out of your mouth. I don't have a clue in this world what you're talking about, but I respect you. I want you to know I'm listening. I'm trying my best. So I am giving you my total attention, but it doesn't imply anything beyond I'm giving you my attention.
Thank you. That's a really excellent example. And as I mentioned in the report, there are tons of quotes that kind of illuminate some of those cultural differences. So I suggest you check it out, especially at least take time to read some of the quotes and hear from the participants themselves. I think you can learn a lot. The next two questions here, I'm going to sort of clump together, and they're both people who are searching for references and resources for developing improved awareness and understanding surrounding this issue. And there's one from a native Spanish speaker who specifically is talking about how it is challenging to interpret in clinical modalities and approaches in Spanish. So do you have any resources in Spanish that use clinical language? So I suppose more broadly, what resources do you have for people who are looking to improve their treatment and approach to working with Spanish speakers?
Let me research that one, and I'll send it to you, Glencora, and then you can disseminate. But one thing that comes out to me, that comes to my mind right away, is that there is an interpreter training course for who's the organization behind the training course?
Yeah, let me interject really briefly here and give you a few more details. There are places that have interpreter trainings for various scenarios, but at DBHDS specifically, we even offer a course for bi or multilingual persons for how to specifically interpret in behavioral healthcare settings, because there are different best practices in a behavioral healthcare setting versus a sort of more standard physical medical setting. And I know that a lot of it's led by Eva Stitt, who is in the chat here. If she can hear me, perhaps she can drop in her email so you can follow up for more information on how to join. It's not specifically for Spanish speakers, it's for any bi or multilingual person. There are a lot more details to it, but yes, there are other organizations that offer interpretation courses. But at DBHDS, yeah, sure.
Sorry. Also, Glencora, if you could share with them the information about the conference, the online conference in September. In reading the titles, it looks like there might be a lot of information available there.
Yeah, I believe that is with the National Latino Behavioral Health Association, NBHLA, and there's a conference. So that's definitely something you might want to check out as well. I'm also going to put Eva's email into the chat, and she's put it into the questions. I'll copy it over here into the chat so you all can reach out for more information. And this is a free curriculum too, as well. Wonderful.
Also, I am doing a culturally responsive workshop for some folks in Hanover, and it's a training kind of workshop. And I'm sure that there are other people who probably do similar workshops about working with people outside your own circle, your own community, your own culture. And as for the clinical language, that is something so specific that I have a book that is it's the Medical Interpreter's Bible or something like that. And it has to do with medical terms, but it doesn't get into the things that the women talked about that, when I was doing the interpreting. But I will check to see if I can find a book that has clinical vocabulary for providing mental health services, because you probably already know this, but interpreting and translating can be very tricky because we have a lot of words that they look like cognates. A cognate is a word that looks very much like a similar word in another language, but they don't always mean the same thing. For example, if I say estoy embarazada, okay, EMBARAZADA, what would be the cognate? What would you be thinking about? I am embarrassed, right? But it means I'm pregnant. So you have to be really careful when you're doing these, thinking, oh, it would be a cognate, and going from there, because you might be saying something that wasn't at all what you intended to say. But I'll check out clinical vocabulary.
Wonderful, thank you. And just to respect people's time, so I'm going to wrap up here with a few final comments. And I will certainly be following up with the resources that Dr. Tilly Lubbs provides me with, as well as the PDF and recording of the presentation. As I mentioned, I put in the chat Eva Stitt's information for behavioral health interpretation training. Additionally, she told me about on the Roanoke Language Access Conference scheduled September 1st to 5th. And it is online and free, so you are welcome to attend that. I can try to put a link in my follow-up email, but she also suggests Googling it. And I also want to briefly mention, as you talked about Hanover, the presentation you're doing there, I believe that is supported by some of the mini grants that we offer out of the Office of Behavioral Health Wellness, Behavioral Health Equity mini grants. So if you all, anybody on this call, ever has an idea of a way they would like to engage the Spanish-speaking community in behavioral health wellness, please reach out to me. I would love to see if the mini grant and the funding opportunity are right for you. And one last time, I'm going to drop the links. Oops, oh, I dropped the wrong thing. But one last time, I'm going to drop the links into the chat. And if you all need anything else, feel free to reach out to Dr. Tilly Lubbs on her contact information or to me. We'd be happy to point you in the right direction. Thank you, everyone. I hope you enjoy your afternoon.
Thank you.